was that's really good. All right, guys. Our day is wrapping up. One more short session. Not sure who was in charge of the agenda and put me last, but guess I need to talk to Ingrid about that one. One quick housekeeping detail. If you somehow were told to park over on the patient parking side, for whatever reason, the parking lot that we had got full. Make sure you exit on the lower level, the south end where the cashier is, and show them your name badge today, and they will not charge you. If you go out on this level here where we, walk in, you're more likely to get charged. So just make sure that you go out that lower level exit on the south end. So, all right. Well, I know we'll be anxious to get out of here, and this is not a very long one, but trying to pull a few things together about Baby Friendly and some maybe clarify some true facts and things that really aren't so true. Once again, a disclosure slide. This was some information I was able to find on the internet to get us a little bit of more current numbers on Baby Friendly around the world. We do have 22,000 hospitals in 157 countries that are now designated Baby Friendly. And some countries have really taken this on as a national public health issue. And, of course, all the hospitals in Sweden are baby friendly. Scotland is really working hard on this. The United Kingdom, England, Scotland, and Wales tend to have some of the lowest breastfeeding rates in Europe. And Scotland is really working hard on this and moving up pretty quickly. And because they have also worked to designate their hospitals. And their data shows that, no surprise there, poverty, and what they call deprivation, families who live in poverty, lack of maternal age, and then baby-friendly status all impact the breastfeeding rates. So that's the data that they have found. And then, look at what's happening in India with the economic changes there and the rising middle class. And so now that's a new market to sell products, and that has really impacted their breastfeeding rates. So, and they do not have very many baby-friendly hospitals in India. So it's very sad to see that. Well, JHL, and Ann had been editor of the journal for many years. In the 2012 edition, they had a whole special issue on baby friendly. So you can go to that JHL issue and see a number of really good articles. But there was one that talked about, what have we learned in the past 20 years since baby friendly was launched. And just some quick facts here that we know breastfeeding saves lives. We're seeing that. Ensuring early effective breastfeeding has long-term impact. We've heard that from many of our speakers today, and particularly Dr. Stubbe's slides. And wrong practices are still out there. We're still separating mothers and babies. We're still giving misinformation. We're still not doing a good job training our staff. But I thought these last two, for hospitals, once you get designated, it's, you don't just stop there, right? Mm-hmm. You have to keep working on it. Things still happen. Something new company, a new contract. I was just hearing about at lunch that's created a new reason to separate mothers and babies, and how do we tackle that? So it's definitely not the end game once you get your designation, but you got to keep working at it to maintain this environment. But I really liked this last one. Baby Friendly is most successful when it's part of the hospital accreditation system. Wouldn't that help us? So, now here, I thought this was really interesting. So now don't panic or don't be too upset. This was from 2012, so we did not yet have our first baby-friendly hospital in Oklahoma. I thought about trying to redo those little things and put us on the map there, but I really just wanted to show you the difference in where our baby-friendly hospitals are. So kind of just study the visual there for a second. And where do we see the higher breastfeeding rates? Do you see a correlation there? Mm-hmm. Let's go back to that for a minute. Where's the gap in our baby friendly? Do we have a big hole in the middle of the country? Of course, we're filling that in. We should have four little balloons there. So yeah, we definitely see some parallels there. Well, you saw this, heard this morning. We have 4 hospitals. And so just to clarify, too, 10% of our babies are born in baby-friendly hospitals now in Oklahoma, and that equals about 7.5% of our birthing hospitals. So the Healthy People 2020 goal is that 8% of our hospitals would be designated. So we're not quite there yet, but one more hospital will bring us to that. So we are this year going to surpass that. I know it. We are going to actually skyrocket past that because we got several hospitals that are going to get it this year, right? I'm looking at you guys. We're counting on you. You have in your packets some of the publications that have been cited, at least in my presentations, and this is data from the health department in a PRAMS brief, and this is here asking mothers, kind of similar to one of Dr. Stubbe's slides, but Oklahoma specific, and what baby-friendly practices were you exposed to? So we can't, once again, ask them, does your hospital have a policy? But the things that the mother could actually answer the question about. So, yeah, you guys are giving out the hotline. We're giving them phone numbers to call. We're telling them to breastfeed on cue. We're helping mother with position and latch. We're keeping babies in the room. So that's really good. But look what we're not doing very good at. 2/3 of our hospitals at the time the mothers were answering this were given gift packs with formula, and 40% of our babies were given formula before they went home. So this is what the mothers are reporting, and we still have 25% roughly that are not breastfeeding in the first hour. So I'm going to just kind of not go through each individual step, but just some kind of interesting newer information that I tried to group according to this 10 steps. So when we look at policy and kind of some key elements under that, such as task force and staff training, some recent information. So this was once again out of that Journal of Human Lactation issue, and some of the facilitators for achieving baby-friendly designation. And so kind of think of, what do we have here in Oklahoma that helps us with this, and maybe what are our barriers even, as a state that we can work on. So do we have endorsement from local and, governmental policymakers? Absolutely, we have that on the national level, and we definitely have strong endorsement on the state level. Hopefully we are convinced of that by coming to the summit. We've had Dr. Klein here 3 years in a row. He makes time out of his busy schedule to come here and recognize our baby-friendly hospital. So we definitely have strong support from our state health department, from our healthcare authority, and our many other partners that we've mentioned. Do we have leadership? Do you have leadership in your hospital? The admin support that Angie Kammermeyer talked about. Do you have a multidisciplinary team? I can tell you, Becky Mantle cannot come to your hospital and make it happen by herself. I did not make it happen at my hospital, and it takes a multidisciplinary team. I can come and help you, and Ingrid and I are definitely here to help you, but you've got to have a team, and that team has to have open communication. We want our anesthesiologist on board, and then, of course, make use of our Becoming Baby Friendly in Oklahoma resources.
Oh, they're already outside?
I'm sorry? Oh, yeah. Muswama, don't leave with our mic.
Let me keep her company.
So, and then another key element that was mentioned in here. Jamie, don't let Muswama. I think Ingrid's going to get it. Yeah. Did he go outside? Okay. Okay. He might be walking to his hotel. Like, bring it back.
Oh, yeah.
So they want training. Of course, the training for staff should be mandatory, absolutely, and should be flexible so that staff can, access it, can maybe get it done during the workday, when there's downtime. And then here's a couple that I think we are still challenged by. Limiting that marketing influence that we've heard about. What can you do in your hospitals to, maybe eliminate the bags if you haven't done that. But we still have that out, of course, in the community. And then step 10, and this kind of really involves as well, but integrating the hospital and community health services. So just a reminder that with the Becoming Baby Friendly in Oklahoma project, we'd certainly love if your hospital has not committed, you can still participate in the webinar, so don't delete those emails that come from Ingrid telling you about the webinars that are scheduled, but these are some coming up. We're going to have some more information on our peer counseling program. Anne's actually thinking about her project and had some interesting ideas, so she will have something really good. And we have Angela Levzarenka from the D.C. area about their military hospital journey. And then Kathy Crothers, as some of you may be familiar with her, she's done a lot of training around the country, is an excellent person to learn about that communication and counseling. And I was really pleased to hear Dr. Stubbe going through the 3-step counseling when in one of her presentations. You've heard me talk about that as well if you've been to some of the trainings that we do. So step 3, maternal education. We've heard of how important this is and absolutely getting the dads involved. But let's look at the flip side of this, as Dr. Stubbe referred to as well. We're not here to pressure and shame and guilt moms into breastfeeding. But this was an interesting article in one of the midwifery journals, and this was actually the title of it. The midwives aren't allowed to tell you. That's the perception that the mother had. If I don't want to breastfeed and I want to give some formula, they're not supposed to talk to me about formula. That's what came out in this survey. So there was a perception that, and I think this was in Scotland as well, but the perception that midwives can't mention formula, so that left the mothers feeling pressured to breastfeed. And then, of course, we've heard this before, conflicting advice, mixed messages, and missing messages. So I'm feeding her too much, I'm not feeding her enough. And, some of the missing messages were just, how this breastfeeding thing really works. What's going to happen when I go home? Some of the information they got wasn't realistic, so the mothers didn't feel prepared at how hard those first few weeks can be, how demanding that can be. So, and then formula feeding mothers. Hopefully we are aware that we are supposed to be teaching the formula feeding mothers safe infant feeding, formula preparation, feeding cues, and all of that. So these mothers said, I had to go home and read the directions myself to figure out how to do this. And that's not what we want either. So what do we learn from this? Well, we don't want people to think that the baby-friendly police are coming and everybody run and hide and put away the pacifiers and hide the bottles of formula. So we shouldn't have to hurry up and clean up the house when our task force chair comes walking through the unit. Oh, put all the babies back in the room. Whatever it is that we're not doing. So skin to skin and early initiation. We've seen some good citations on this earlier today. This was a really new one that came out just last month in pediatrics. Now this is, of course, on preemies, our low birth weight babies. But look at this. If anybody needs convincing, this was a meta-analysis, so of course summarizing the data from numerous studies. Lower mortality rate. Okay, I'm done, right? I don't need anything else on this list, but these also help. Less sepsis, hypothermia, you guys know this, but increased exclusive breastfeeding, of course, higher O2 sats, temperature, better head circumference development. So, but let's look at what many of you are working on. So here's a couple of newer articles you might want to cite, looking at skin-to-skin contact after cesarean section. What we do know that's very clear is some of the environmental factors that also occur with even routine scheduled cesarean sections lead to lower breastfeeding rates. And we can impact that by applying skin to skin in the OR. So, and this one study was in Vietnam, where they found that when they started skin to skin in the OR, the mothers who were getting that early initiation after cesarean actually had similar breastfeeding rates to the mothers who had delivered vaginally. So it did make a difference in their success and their duration with breastfeeding. And then the other study found that this early or immediate skin to skin, we had more initiation, we breastfed sooner, we didn't supplement, we maintained temperature, reduced stress. Aren't we all wanting to reduce the stress of our babies? So, and probably reduce mom stress too, but that wasn't cited. So, all right. So steps 5 through 9. I'm not going to go, through all of these individually, but some things that kind of apply to that whole package of, providing the environment, teaching the mother, feeding on cue, and so forth. keeping them mothers and babies together. So, are we doing this or not? This was a study from 2009 that actually Miriam Labach, that some have mentioned today, was involved in. So, and it found that almost half of the first-time mothers who intended to exclusively breastfeed said their babies got formula in the hospital. So how supportive were we of that mom's goal? 45% said they were given pacifiers. Now, if that mother delivered in a hospital that practiced 6 to 7 of the 10 steps, once again, that's what the mother would be able to report that she experienced, they were 6 times more likely to achieve their goal of exclusive breastfeeding. And mothers whose babies were not supplemented, now this I was really astonished by. The primips were 4 times more likely to achieve their goal, and the multips were almost 9 times more likely. So, she's an experienced mom. She's breastfed before. We don't have to. She can do whatever she wants to do. It's like, no. We still need to educate her about feeding cues and volume of milk and milk intake and so forth, and encourage and reassure her as well. So what we also know is baby-friendly impacts disparities. So we had a whole day yesterday talking about inequities and disparities. But this is from Oklahoma, guys. So mothers who had insurance from work or the military were more likely to experience the baby-friendly practices than our mothers on Medicaid. That speaks directly to our hospitals and our healthcare providers. That should be a wake-up call to us. And we know from some of Dr. Meerwood's research that breastfeeding rates in baby-friendly hospitals went up across all socio and racial and socioeconomic levels. So everybody had improved breastfeeding rates when they delivered in a baby-friendly hospital. So it does address those inequities that we see. Now, of course, how many of you hear from your physicians, well, we've got to supplement because they're not getting enough and we can't send these little dehydrated babies home. And I know one hospital says they still struggle with pediatricians who require a blood sugar on every single newborn, whether they're, whether there's, falling into any kind of protocol, low birth weight or SGA or preemie. It's every single baby gets their blood sugar test because we got to make sure they're not going to go home dehydrated, right? So what we do know, and this was also a very new article in the Journal of Human Lactation, that they tried to survey the literature on risk factors for breastfeeding-associated hypernatremia. And, the one thing they found was we certainly need some more research on this, but here are some of the risk factors: C-section, first-time mom, breastfeeding problems. Here's our BMI that Dr. Stubbe mentioned, delayed breastfeeding, lack of previous experience, low education level on the part of mom. So what does this tell us? This tells us that when we put those baby-friendly practices into place, hopefully we're going to reduce some of these risk factors, and we're going to be more aware that they are risk factors, that we have a high acuity breastfeeding couplet walking out the door of our hospital. What are we going to do about that? What's the immediate referral that we need to make for that mom and baby so that they don't get into problems? So hopefully it will raise our awareness of what other processes we need to put into place. Does that make sense to everybody? Step 6, kind of pulling this one out. It's the special one, right? The exclusive breastfeeding and the marketing piece. So, and don't you like my organic formula picture? You can find all kinds of cool pictures about organic baby formula. Now, notice the label on the back. How many times do they bold organic there for you? And how many other ingredients do you see? So I thought that was, and it's certified USDA organic, certified organic by Quality Assurance. Okay. Marketing, that's all marketing. Well, how much does it cost? So you have a copy of a couple of these publications in your packet today. This was a large hospital and 2,200 deliveries a year. looking at how much they thought they would spend on formula when they went baby-friendly. And ultimately, they found that they spent a lot less than they projected. While they did spend a little bit more on preterm products, their overall decrease in expenditure for term formula really kind of balanced that out. So that's one. Without getting into, it's kind of hard to predict, actual dollar amounts. Another one that we've cited before, this was in pediatrics in 2011 when they looked at DRGs, the diagnosis-related group codes between women who delivered in a baby-friendly hospital versus women who delivered in a non-baby-friendly hospital, and there was no significant difference in the cost. And anecdotally, I don't know if I were to ask some of you, but some of you I know have told me this as you start working on this, that you buy a lot less breastfeeding equipment too. You maybe use fewer breast pumps, and pacifiers are expensive. When you start, and many of you are paying for pacifiers already, and if you stop giving those out, that probably covers quite a bit of the formula cost right there. I see some heads nodding. So a lot of that's going to be fairly cost neutral. Now, this was an economic cost analysis, because this is, what your administrators are going to want to know about, and Angie mentioned this as well. But this was a study that was done in Texas. It wasn't published in a journal, but it was it's available online and out of, I think, UT San Antonio. And so if you look at the blue, A is the best case scenario. So they found that as they started working on baby-friendly and they got designated and they really hardwired these practices, the cost was maybe 2% per delivery, or per baby. And that cost really declined down to maybe 0.5%. And so they said that was not a significant difference in cost. But when you don't really have all your, steps in place, of course, some of your costs are going to be a little bit higher. But they also surveyed these hospitals and found that, of course, they had good PR in the community. There was more interest in the community about what the hospital was doing. They felt they had better patient outcomes. They had higher rates of breastfeeding. So that all of those positives outweighed any concern about the cost. Well, Lori Feldman-Winter, who has been here to speak for us before, was the lead author on this study in JHL, looking at industry-sponsored formula packs. Did it really impact breastfeeding rates? And this they actually took, it was a prospective study, so they had mothers who, about 400 mothers who delivered in hospitals while they were still giving out the formula bags. And then they went to hospitals that had those hospitals eliminate the bags and then monitored to see the breastfeeding rates of mothers who delivered after that. So this was really interesting. Now, they did find that the mothers who didn't get formula in the take-home bag, whatever kind of little gift bag the hospital gave them, had higher exclusive breastfeeding rates. But the women in the intervention group who should have gotten a formula-free take-home bag actually did not. Somebody was sneaking formula into the gift bag. So, yeah. So overall, their study was contaminated, and they couldn't, draw some, firm conclusions to that. But they did show that we think we're bag-free, and we're not. We're still giving out those free formula samples. Somebody is. So we need to look into that. Bag-free states. We actually have 4 states now that are none of the birthing hospitals, and including D.C. So I guess we don't say D.C. is a state, but so we have states where every single birthing hospital has eliminated the industry gift bags. And data from the CDC, from the MPINK survey, that we now have over 900 bag-free hospitals. U.S. News and World Report had some data out in a couple of years ago that 2/3 of their hospitals that they reported as being, the top 100 hospitals, 2/3 of the, not top 100, but the top 100. So 30 out of those 45 hospitals were not distributing formula gift bags. So, of course, their call was to the other 15 to say, you guys, if you want to stay on this list, you got to take care of this problem. So we're now, according to this one article in Pediatrics, almost 70% of hospitals around the country now that report not giving out the formula bags. So, of course, there's our list, 29 of our 53 birthing hospitals. And if your hospital's not on this list, talk to me and let's make this happen, right? I know some of you who have done this, some time ago can tell you really how easy it is. And it wasn't as hard, and there weren't any complaints from patients. It wasn't near as scary as they thought it might be. And it's a very positive step that you can take. So how are we going to get to 100% of our hospitals? You also have a copy of Marcia Walker's article that was in Joggin last year that's really directed at nurses and healthcare providers about the risk to your career, possibly, of distributing these free formula samples. Of course, we know powdered infant formula, which is in the bags, is not sterile. There are recalls. It's going to alter the gut programming. Of course, we're not going to have as much breast milk to the baby. And even the formula bags have been recalled. So you can take that to your hospital ethics committee and talk about, guys, we aren't tracking this. Can we contact these families if we send them home with these products that we're not even sure they're safe anymore? So that's why would we waste any time and effort? You have a lot better things to do with your time than worry about supporting the formula companies. Last but not least, step 10, the November JHL issue was completely dedicated to community resources, so a lot of articles in that, a lot of different information. Once again, one article analyzed discharge pack information, looking at the educational materials that are sent home. How good was the information? Was it covering enough information that the mothers needed to know, and found pretty wide discrepancies in that. So something else to keep in mind, who's in charge of that, and are we sending our moms home with quality information and reading level appropriate information, and information with diverse images. So it's going to be, helpful and supportive to the mothers. New York State has a breastfeeding friendly practice designation. Ooh, let's help our docs in their clinics work on that. Of course, some of our states, in some of these articles, the states collaborated with community clinics. Make use of your breastfeeding coalition. Of course, work with our coalition. That's what many of the articles were about. And then, of course, make use of our breastfeeding hotline. So to wrap up here, just a few slides to remind you, if you're not participating in Becoming Baby Friendly in Oklahoma, we have a lot of resources to help you guys. Monthly webinars, technical assistance, Ingrid and I available by phone, email. We'll come out to your hospital. We'll meet with your docs, your leadership, whatever you need. Of course, we continue to build our website and try to make resources readily available. So let us know if you can't find something, if there's something you think would be helpful to have. I think a big piece is mock surveys. When you are ready to have somebody, we'll come and do a mock survey, and I know that's been very helpful. But there's also money, so you get some financial support. You'll get an enrollment stipend. Complete a few steps there, and then as you go through the three big phases, as you complete those, you'll get some financial support for that too, some reimbursement. I'm not going to go through the 4D pathway. You guys can, see that. But this is our website. We have this, whole section on baby friendly, but we've got other resources here. That's where maybe policies and links to AAP stuff. Here's where some of our data may be. And we're going to really work to try to build up the patient material. Some of the links that you've seen in the presentations, and we're going to try to kind of compile all those in one place. We're also working to make some things available that I know some of you like the handouts but can't print them out, so we're going to try to make those available where you can order them, really kind of at wholesale cost to cover our cost. These are little badge buddies we've just developed, so if you want to purchase those for your staff that can, attach to their name badge, and it's got, the volume of intake, size of tummies, and here's kind of the key baby-friendly bullet points to hit with mothers, say during the prenatal education. So trying to come up with some different resources. But getting started, of course, get your hospital leadership support. We can help you with that. Let us know when you're ready to start, and let us know what you need. We're here to help. So And there's our information. So, all right. I think I'm done. Ingrid's telling me I'm done too. So we really appreciate everybody coming today. You asked good questions. How'd y'all like that dad's panel? Yeah. That was good. That was very brave of our dads to sit down here.